Hello, everyone. My name is Maully Shah. I am the Director of Cardiac Electrophysiology at the Children's Hospital of Philadelphia. And on behalf of PedirhythmX, I'm going to be talking about leadless pacing. This audience is very familiar with the risk of complications with conventional pacemakers. Despite the life-saving nature of pacemakers and improvement in quality of life, the risk of serious complications at 2 months after pacemaker implantation reaches 12%, and this risk increases to almost 20% at 5 years after conventional pacemaker implantation. Nearly half of these complications are due to lead and generator-related complications. In our lifetimes, we have all seen serious pocket complications with pocket infection, pocket hematoma, and pocket dehiscence. Pacemaker generators can migrate, and here you see a child with an abdominal pacemaker implantation. The generator then migrated to the pelvis, and in another child, the pacemaker migrated to the descending colon. This is an extreme example of pacemaker migration, and unfortunately, this generator has now completely exteriorized. And this was actually a published case report in 2006. This audience is also familiar with lead failures, both transvenous and epicardial, especially in growing children, and lead extraction of long-term indwelling leads has a high risk of complications. Now, either due to the presence of transvenous leads themselves or complications of congenital heart disease procedures, many of our patients lose vascular access at an earlier age. Leadless pacemakers, by their very nature, eliminate the likelihood of pocket and lead complications. And with this goal in mind, the US FDA in 2016 approved 2 leadless pacemakers. The first was NanoStim from St. Jude Medical, and this was followed by Micra VR from Medtronic. The NanoStim was taken off the market due to battery problems, and therefore most of my presentation will include only Micra VR from Medtronic. In 2021, the FDA approved the Micra AV, which is a software platform of the Micra that allows for atrioventricular synchrony. And in 2022, the FDA approved their single chamber ventricular pacemaker from Abbott Medical. As you can see, the Micra is very small. It's a fraction of a conventional pacemaker. It's often compared to the Washington quarter or a small capsule. It is less than 1 cc in volume. It is about 26 millimeters in length and 7.6 millimeters in width. This is a magnified version of the Micra, and you can see that it has a steroid-eluting tip cathode. The fixation mechanism is passive, and it consists of flex-fix nitinol tines. The battery and the processing unit are self-contained in a single unit, and there's a small retrieval mechanism at the proximal end of the device. The estimated longevity of the battery is 5 to 10 years, depending on the capture threshold as well as battery usage. And the Micra VR has all the capabilities of conventional pacemakers, and notably, it can also be turned off. Now, one might think that the leadless pacemaker is a 21st century invention. The concept of a leadless pacemaker was first conceived in 1970 with successful implantation in dogs. And as you can see here, the 1970 prototype of the leadless pacemaker is very, very similar to the Micra that we see today in the previous pictures that I just showed you. Now, the reason why this pacemaker was not successfully marketed in 1970 is because there was a lag in battery technology. And at that time, the only extended batteries were nuclear powered batteries. And therefore, the leadless pacemaker that was first invented in 1970 had to be shelved, and the technology resurfaced only in 2016. Now let's look at the micra implantation tools. It consists of an introducer sheath with an outer diameter of 27 French, which is about 56 centimeters long. The delivery sheath is a 20 French delivery sheath. The device itself is preloaded and is sealed in a cup and tethered to a catheter, allowing recapture attempts until satisfactory placement of the device and optimal electrical parameters. Now here you can see how the micra is deployed. This is a ex vivo demonstration of how the micra is deployed into the heart. This is our first case of the micra. We implanted our first micra in 2017 in a patient with tetralogy FLO who had multiple transcatheter interventions with severe tricuspid valve regurgitation and paroxysmal high-grade AV block. And here you can see that the micra is still seated in the delivery cup, and the location for device implantation can be determined by contrast injection through the delivery catheter. And here you can see that we're puffing some contrast in, and the goal is really to seat it in a septal position, and utilizing both RAO and LAO views is useful in determining the location. Now here you can see that the micra is still tethered to the delivery catheter and will be released only after optimal electrical parameters are achieved and septal placement is confirmed. And then on the image to your right, you can see that the micra has now been fully deployed and the catheter has been removed. Now, we know that the micra can also be implanted through the internal jugular approach, and there are publications that have shown both the percutaneous as well as a surgical cut-down method. So I know this is a busy slide, but this slide essentially summarizes all the published data from the pivotal micra trial, the post-approval global registry trial, and the Medicare longitudinal study in adult patients. And all these studies have demonstrated a significant risk in complications compared to transvenous cohorts, along with excellent maintenance of electrical parameters at 6 and 12 months of follow-up. There is a comparable 30-day all-cause mortality between the leadless pacemaker and the transvenous cohorts. The major risk is cardiac perforation, but the prevalence or the incidence of cardiac perforation is low. It's 1%, and it's comparable to transvenous leads. And there's a low risk of infection with the leadless pacemaker, and thus far, none of the devices have needed removal. I just want to talk a little bit about the micra AV. The AV synchrony mechanism in the micra AV leadless pacemaker differs from standard pacemakers in that the ventricular accelerometer senses mechanical rather than electrical atrial activity. This would be equivalent to the A wave on the Doppler echo or the S4 heart sound related to atrial systole. This algorithm is not designed to track atrial rates greater than 105 beats per minute. And this is due to merging of the A3 and A4 mechanical components. So now let's look at some of the real world pediatric data on the leadless pacemaker. And this has been captured in the transcatheter leadless pacing study in children, which is a PACES collaborative study. And you can see that there are 15 institutions that have participated in this study. We included patients who had the micra implanted between 2016 and 2021. There were 63 patients who had come to the cath lab for intention to treat with a leadless pacemaker. All patients were less than 21 years of age, and 62 out of the 63 patients had a successful implant at an average age of 15 years, but you can see that the youngest patient is 4 years of age. The average weight was 55 kilos, with the smallest patient being 16 kilos, and the average follow-up is 9 months, but the longest follow-up is 5 years, and 35% of our patients have greater than 1 year of follow-up. 30% of the patients had congenital heart disease, and 8% of patients had genetic abnormalities. Most of the patients were implanted via the femoral venous route, but 8 patients were implanted via the internal jugular vein, and 66% of patients had pre-procedure venous imaging of the vessel through which the device was implanted. Now let's look at the pediatric patient selection for leadless pacemaker in the registry study. None of the patients were pacemaker dependent. 63% of patients had either AV block or AV node dysfunction. This included 10 patients with congenital complete AV block, 5 patients with postoperative AV block, and the remainder were patients with some form of idiopathic paroxysmal AV block. 37% of patients had sinus node dysfunction or sinus pauses. This included 2 patients with asystolic cardiac arrest, 2 patients with postoperative sinus node dysfunction, and there were also patients with vasovagal syncope and patients with epilepsy. 23% of patients had prior devices. This included 5 transvenous devices and 9 epicardial devices. There were 8 patients with prior lead fractures and 9 patients with device infections. However, the Micra pacemaker was the index device in 77% of the patients. Similar to adult studies, the electrical parameters at implant, as well as 6 and 12 months of follow-up, were excellent. In 96% of the patients, the capture threshold at implant was less than 2 volts, and it was less than 1 volt in 83% of the patients. During follow-up, the capture threshold tended to decrease, the R waves increased, and the impedance had a tendency to decrease. Now let's look at the complications in the pediatric cohort. Early complications occurred in 11% of patients. This included mostly bleeding from the venous site, as well as hematoma. 1 patient had arrhythmia and actually just right bundle branch block changes on the ECG. 1 patient had pacemaker capture problems, and this is actually the unsuccessful implant where the pacemaker was removed, and this was felt to be more of a patient substrate issue than a device issue. This patient had Emery-Dreifuss syndrome, and on MRI, there was already extensive myocardial scarring. Now, there was a pericardial tamponade in 1 patient, and we're going to talk about cardiac perforations in a little bit. As far as late complications occurred, these occurred in 3 patients. 1 patient had pacemaker capture and sensing problems, and 1 patient had R-wave sensing problems. The patient with the R-wave sensing problems was subsequently treated with steroids and with improvement. However, the patient with pacemaker capture problems needed pacemaker retrieval and reimplantation of a new device. So let's talk a little bit about leadless pacemaker perforations. Now, we know from the adult registry studies that this risk is low. But the point I want to make here is that when the MAUD database was searched, there were 563 Micra perforations. Now remember that we don't have a denominator here. And so the MAUD database only records what was reported. by implanters. The important aspect of this data is that at least 1/4 of the patients who had a cardiac perforation died either directly or indirectly due to the perforation. And almost 50% of these perforations were related to either device problems or operator use problems. Now, when we talk about device problems, the problems were because the device needed to be reimplanted multiple times because of suboptimal electrical parameters. And in terms of operator use problems, the issues related to perforation, not just related to the heart, but also extracardiac perforations. It's also important to note that in almost 25% of the perforations, surgical intervention was necessary. So how do we avoid cardiac perforations? And it's important to really learn the fluoroscopic right ventricular anatomy for implantation. So we want to avoid implanting on the anterior free wall, the apex, and the inferior wall, because all these areas are less than 5 millimeters in thickness. So your target zone really is in the mid to distal right ventricular septum. So if you look at the figure on your left, if you implant too high on the septum, you run the risk of being too close to the tricuspid valve. And you also might end up in the smooth portion of the right ventricular outflow tract. And so you're less likely to be nested in the trabeculations. If the device is implanted too apically, then as we said, the true apex is only 1 millimeter thick, and you run into a high risk of a cardiac perforation. A disadvantage of the leadless pacemaker is that the micra is not designed for chronic retrieval or extraction. And as you can see in the picture on your top left, within a few months, the micra can be completely encapsulated. And therefore, if the retrieval mechanism or the docking button, which is right here, if this is completely encapsulated, there's really no good way to retrieve this. And in adult studies, they've shown that up to 5 micras can be implanted into the right ventricle without removal. Now, this is certainly not something we want to take on in our pediatric patients. But despite the device not having a dedicated retrieval system, there are numerous case reports of the micra being extracted with currently available extraction tools up to 5 years after implantation. Now, just a few words about the recently approved AVEIR pacemaker. So this pacemaker has a design which could mitigate some of the micra problems. Notably, it is designed for chronic retrieval. So as you can see here, it looks very similar to the micra, but it's a little bit longer and a little skinnier. The battery longevity is projected to be twice as long as the micra. The delivery mechanism is very similar to the micra, but the delivery sheath is available in 2 lengths. So there's a 50 centimeter and a 30 centimeter sheath available. The shorter sheath may be useful in the internal jugular venous implants. Now, this device is not preloaded, and this is an advantage, so that the delivery cup is actually quite soft and flexible. Most of the micra perforations are related to the stiffness of the distal end of the delivery catheter, and this is because the delivery cup is stiff as the device is preloaded in that delivery cup. So in terms of the fixation mechanism, the AVEIR has an active fixation helix screw. And another advantage is that passive mapping of electrical parameters can be performed without fixation. So this may actually reduce the risk of perforation. So you don't have to fully implant it and then retrieve it if your electrical parameters are suboptimal. So you can pretty much touch the electrode to the myocardium and then obtain electrical parameters without any type of fixation. There's a specifically designed docking button, as you can see right here, and this is for chronic retrieval. And there's a dedicated tri-loop snare catheter retrieval system, which is designed specifically to retrieve the AVEIR leadless pacemaker. So now we've established that we can successfully implant leadless pacemakers, but the question in pediatric patients is, should we? Some of the disadvantages of the transcatheter leadless pacemakers in pediatric patients are that there is currently no atrial pacing. So these pacemakers are not suitable for significant sinus node dysfunction. Atrioventricular synchrony is limited to a heart rate of 105 beats per minute. Again, this feature is not suitable for pediatric patients who need higher rates and higher AV synchrony at higher rates. And despite case reports of retrieval, there's really no reliable way to extract the leadless pacemaker at long-term follow-up. So what are the indications for transcatheter leadless pacemakers in the pediatric population? I think this device should be reserved for patients with anatomical and vascular issues that preclude conventional pacing. Another indication is in patients who've had complications with a traditional pacemaker, in patients who've had pocket erosions, in patients with tricuspid valve disease, in young patients where preservation of vessels is desired, and in patients with transient pacing needs. An example of this would be a patient who is awaiting heart transplant, or a patient who has limited lifespan, so that the patient may actually outlive the longevity of the device, or patients who may outgrow permanent pacing needs. Now, recently, based on our shared decision-making model, there has been an explicit patient preference for the leadless pacemaker due to its cosmetic and psychosocial benefits. In these situations, a clear risk-benefit conversation must be undertaken before implantation of a leadless pacemaker in a child. So looking into the future, what's in the works? There is a leadless dual chamber pacemaker, which is in clinical trials. This is the AVEIR DR I2I implant-to-implant clinical trial. And I believe the first in-human pacemaker has been implanted earlier this year. Interestingly, the technology used for communication between the two devices is a modality that employs subthreshold electrical signals conducted between the two leadless pacemakers through the blood and myocardial tissue on a beat-by-beat basis. Another exciting leadless pacing technology is a combination with the SICD platform. This is currently in the modular anti-tachycardia pacing clinical trial. This device is the Empower leadless pacemaker, which is paired with the Boston Scientific Emblem subcutaneous ICD to provide bradycardia therapy, as well as command ATP therapy for anti-tachycardia pacing of ventricular tachycardia. And finally, the third leadless pacemaker that is in clinical trials is the wireless stimulation endocardial CRT system for endocardial left ventricular pacing. This is a unique system that consists of 3 parts. The first is a transvenous right ventricular pacemaker. The next is a subcutaneous ultrasound transmitter or pulse generator. And the third is a percutaneously placed left ventricular endocardial receiver, which is seen in figure C. It's very small. As you can see, it's only about 12 millimeters in length. And this is a receiver electrode that converts ultrasound energy into electrical energy and delivers an electrical stimulus with, which is in synchrony with the right ventricle. So as you know, almost 30% of patients fail conventional CRT or are not candidates for conventional CRT. And this is a promising device for those patients. So in conclusion, leadless pacing is an exciting new technology. There is a high rate of implant success in adults and in children. Real-world data show reduction in pocket and lead complications. Cardiac perforation incidence is low, but the complication is a serious complication. There's a need for rigorous training for leadless pacemaker implantation. And because of the low pediatric volume, the experience should be concentrated to select trained operators. And we need further clinical guidelines for pediatric patient selection. Thank you very much for your attention.